Okay, since we had such a big response to this topic, I thought that we would go ahead and record it so other people can watch it. But Brianne was the one who had suggested alternative positions. And so obviously we teach it in the part 1 and the part 2. But a lot of people don't end up using it or don't use it much. And even Joanne and I were conversing about positions that we've not used much over the years. So for those of you who I can see, can you just like raise your hand if you do use alternative positions in your practice? Okay, all right, so everybody, all right. Heidi, do you? Okay, all right. So what I'm going to do is I'm just going to kind of do a review. How many of you have your manual? Did anybody grab their manual? Good, yeah. So go ahead and use use that as well. I pulled that out, and I went ahead and just kind of did a PowerPoint, pulling together some of the information about them. So I thought what we'd do is we, just kind of run through them. Now, I did not get to the actual like developmental ones just because I don't have pictures of them and I didn't want to keep stealing AHA's pictures, but we can certainly discuss them. So that's like quadruped and tall Neil. But wanted to go through the other positions and just talk about, why we use them, what are the advantages, and what are some considerations we need to keep in mind as we're choosing them. But before we even start with this, and this is as much for anybody watching this in a recording later, the probably the take home that I want everybody to think about with regards to this is that the less is more. Okay, the idea that people think, oh, because I've learned all these positions every 5 minutes, I'm going to switch my patient into another position is not the takeaway message here. The idea is to learn about each one of these positions, but just like with your clinical reasoning with regards to horse selection and equipment and handling selection and treatment progression, it's just all part of that. You want to have a rationale for why you're doing what you're doing. Oh, there's Brianne. Brianne, I'm glad that you're here because you are the instigator for this topic. All right, so let me go ahead.
Husband's out of town, so I have all the kids solo tonight.
Oh, okay. I was like, where is she? She's the one who started this thought. So anyway, thank you for doing that. I'm going to go ahead and screen share and just go through. So as I screen share, I cannot see you guys and I don't pull up the chat box. So if you have a question while I'm presenting, please just, turn your mute off, open your microphone, ask the question. Otherwise, we'll talk afterwards. But please, if you've got a burning question while we're talking about a specific position, please ask. Okay. So just, again, some of these things to think about with regards to these different positions we're going to be talking about is that positions can be challenging. They can be challenging for the horse. They can be challenging for the therapist and the sidewalker. And certainly they're designed to be challenging for our patients. And the idea is with anything that we are choosing for our patients is the idea is that we want that just right challenge. We don't want something that's too easy, but we don't want something that's too hard. And so we need again to have that rationale as to why we're selecting this. We realize that this may create anxiety. The transition itself may create anxiety, and certainly the position, certain positions even more than others based on different aspects that we'll be discussing. Really, for the most part, most of these are not designed for large children and adults. They are more designed for smaller individuals. Again, you need to have a well-trained horse that's going to be comfortable with these positions and comfortable with just the transitions of getting them in and out of those positions. And then other than face forward straddle sitting, saddles are not appropriate for these other positions. All right, so forward facing straddle sitting, that's a position. It's just not an alternate position, but it's the one that we tend to use the most. It's the one that the research has mostly been performed based on, and it does provide a lot of benefits for our patients. And, you know, one we can just really appreciate as we look at this picture here is just having the horse between the patient's legs so that the patient has a good base of support. And the other thing is that the visual vestibular information is happening in a typical manner. So as far as considerations, we realize that our patients must accommodate that horse's frame. So, you know, we learned in their part one, as far as, you know, selection of the horse, that we need to have an appropriate width for our patient. Again, they're getting the visual and vestibular information the same as is typical in life, and that's that getting the visual flow, that as the patient is moving forward through space, that things appear to be moving towards them. It provides a language-rich environment. It's the least likely position to create anxiety. And then because of the nature of the slope of the withers into the back, it does tend to promote a bit of a posterior pelvic tilt. So it's just something we need to keep in mind, in that if we've got issues with getting our patient into a more neutral position, that sometimes an alternative position may be more appropriate, at least temporarily. All right, so again, as far as the use of alternative positions, we're going to consider things such as developmental sequence. So again, it's like, you know, what are we going to do first in our treatment progression? What are we going to do next? We're going to think of the things that are lesser challenging for our patients before we add greater challenge. That we're using this, again, for a particular reason. Having that clinical rationale. And then basically, bottom line, have a plan, and that more is not better. Those are the takeaways. All right, so probably if the most common next position, other than forward facing straddle sitting, is rear facing straddle sitting. And there's a lot of things we need to take into consideration with regards to this position. So again, because of the slope of the withers into the back, this is going to facilitate an anterior pelvic tilt. With the anterior pelvic tilt tends to come an improvement in thoracic extension. It provides a really wonderful weight-bearing surface for upper extremities, and it can be a starting point for some other developmental positions. And for the speech and language pathologists, thinking about the increased jaw grading and mouth closure. One of the things we really need to think about, and again, this is going to be in the considerations as well, is that it provides a wider base of support. And we have to make sure that, and that's because of the barrel of the horse, the belly being right there where the legs are. We need to make sure that we're not providing too great of a challenge with regards to that. So this is also providing a visual vestibular mismatch. So this is that, the visual flow is no longer appearing like things are moving towards the patient. Now things are moving away from the patient. And so some patients who have some sensitivities may not tolerate that. And as a result, they may have some disorientation or some increased anxiety. So we're watching their behavior to make sure that they're tolerating this, this position and this sensory information. Because of the width of the barrel, we have to make sure that we're not causing an increase in muscle tone, specifically the hip flexors and the hip adductors. Again, just what I was talking about earlier, that we may be creating too great of a biomechanical challenge to the hips with that width. And you still need to have your sidewalkers facing forward. I just, I would have such a variety of volunteers. And it would be funny, we'd turn the patient around and they would turn themselves around and I'd be like, nope, you still need to face forward. Side sitting is completely different from straddle sitting. So, whether you're forward facing or rear facing, when you're straddle sitting, you've got a horse underneath you. You've got a horse between your legs. And now when you're side sitting, your patient doesn't have that. And so this can be a very beneficial position, but it can also be very, very anxiety producing. So I'm going to go to the slide here on benefits, and I may backtrack again for a moment. So the idea is that we're facilitating weight shifts with our patient side sitting, and we're primarily going to get that shift to the tail end or the caudal end of the horse. So you're going to be thinking about, okay, why would I position my patient's left side to the tail end of the horse? Do you want to start in this position, but you eventually want to get them so that their right side is towards, realizing that they're going to get a greater challenge. So be thinking in your head about, which side are you turning them to, and is there a reason, or are you just, they don't really have an asymmetry and you just want to provide them the opportunity perhaps to both sides. We're facilitating flexors and extensors in the sagittal plane, as well as flexors and extensors simultaneously in the frontal plane with that side to side. So the thing we have to remember is that not only are we getting the drop of the hind end, but remember how when the patient's facing forward and you're tracking, say, to the left, we know that our patient gets a greater drop to their right side or to the outside of the arena. And so the same thing's happening when they're inside sitting. So if you imagine that the horse is tracking left and the patient is facing the outside of the arena, they're going to get a greater shift forward. So a greater shift forward is going to be accentuating their extensors. If they were tracking left, but they were facing the inside of the arena, as they would shift they would come into like a posterior pelvic tilt. They would be leaning towards the outside of the arena, and it would be facilitating their flexors to maintain an upright position. So not only are you thinking left and right, but you're thinking facing inside or facing outside, depending on whether you want to be focusing on flexors or extensors. Also, while the patient is side sitting, you're getting a hip rotation with that weight shifting. So if you imagine that this is the tail end of the horse and the patient's knees are right here, the patient is getting an external rotation on the hip that's closest to the tail end of the horse and an internal rotation of the other hip. So this is one way that we can use to facilitate, getting more external rotation to that one hip. It provides an opportunity for upper extremity weight bearing. So, again, if the tail end of the horse is here, the patient has placed their hand next to them, where the rump of the horse is, gives them a surface on which to weight bear. It's also improving their respiratory support, providing coordination of respiration and phonation. And to me, one of the most lovely things about it is if you, as the therapist, are in front of them, you've got great ability for direct eye contact. So I'm just going to, let me go back. So again, let's just think about, let's see if I can get my laser pointer here. So if this is the tail end of the horse and this little patient was putting her hand flat, you can see she's kind of stabilizing herself a little bit by holding on to the pad. But what we'd really want is ideally a little larger pad here so that she could be placing her hand here and getting more weight shifting to that side. The other thing you really want to think about, and I have this under considerations, but we may as well talk about it while we're looking at the picture, is how are you going to put your hands on the patient? How are you going to support your patient to make them feel nice and secure and to give them the best benefit? So you can see, this is actually my hand right here, hands on the pelvis. So right on the top of the pelvis, giving a little bit of downward pressure and yet going with the lateral tilt that's being created as a result of that weight shift so that they're feeling nice and secure. So giving a little downward pressure is just making them feel more secure. But still, they're going to have that tendency to feel like maybe they're sliding forward. So what I like to do in front of the patient is to have hands, this is my technique. Everybody's going to be a little bit different. I like to have hands directly under the knees. So you can see here how she's got the hand under the knee, and she's providing a little bit of approximation in towards the horse. So between this and this patient feels nice and secure on the horse. Also, as she's getting that weight shift, it's towards her left, you can, with your hands there, help to facilitate that rotation for the external rotation of the hip that's closest to the tail end of the horse. And then with regards to, the considerations, again, we're really providing a much narrower base of support. We've taken that horse out from between their legs. We realize it can create anxiety and cause stress, and it can certainly aggravate the vestibular system. So we need to be monitoring for those things. Again, thinking about hand placement. If you don't, I'm giving you one idea. But always be thinking about, okay, when my hands are here, what am I providing for them? Am I giving them security? Am I facilitating? Why are my hands where they are? Opportunity for facilitating many options. So be attentive. So like I said, you can facilitate flexion, you can facilitate extension, you can facilitate lateral flexion, you can facilitate external rotation of one hip. there's so many different things you can be working on. So you need to be attentive to that. And also just realize that if you needed to grab them off quickly, you know, that this emergency dismount is going to look different than if they were in a straddle sit position. So you need to be prepared for that. And again, one of the reasons why smaller people are going to be more appropriate, because imagine a big person up there, if you had to slide them down real quickly, how would that look? All right, modified sit position is not one that I have used much, but as you can see in this picture here, the one leg looks pretty similar to a face forward straddle sit. But if for somebody who can't fully straddle sit, you can abduct and externally rotate and flex that hip and have this leg basically supported up at the withers. So the benefits are that you're getting a lot of dissociation. You're getting dissociation of the trunk from the pelvis from the hips, and basically one hip from the other. If you've got a little patient that's got more involvement on this side, then it's a way of getting them to get a little bit of weight borne on that side. It promotes elongation of the trunk on that side that's closest to the withers. Therefore, it's promoting trunk symmetry. Because of the nature of the position, we are facilitating some trunk rotation, which you can appreciate here. It improves coordination of respiration and phonation, and it can be used as preparation for maybe getting them to the point where they can straddle sit. But you're going to need to be thinking about how are you going to support the patient? What's your handhold going to look like if you choose to use that position? And it is going to alter sensory input. And then one thing you might consider is the use of a two-handled surcingle. If we had a two-handled surcingle here, a handle here, but then a handle on the other side, this knee actually might be kind of wrapped around that other handle. So it just would give a little bit more security. It's just another option. All right, I pulled this one out of the archives. So prone over the barrel. This is probably, of all the alternative positions I've used besides rear facing, this is probably the one I've used the most. I've used this one with a lot of my patients who were very involved. One of my very first patients I ever had on a horse only used this position. She had one anteriorly dislocated, one posteriorly dislocated hip. She was institutionalized and had a very, very strong asymmetry. And then also I had a patient who had too severe of a scoliosis to sit, but the benefits that were attained even in this position were substantial. So I really love this position. And then of course I have used this to decrease spasticity, increase range of motion, and to attain adequate range of motion and reduction of tone to be able to then sit my patient in straddle sitting. All right, so as far as benefits, we're providing tactile and proprioceptive input with increased contact area of the body. They're getting a lot of vestibular input. As a pelvis gets when they're on the horse, such as your patient getting. So your patient is feeling an anterior posterior movement. They're feeling a lateral shift. It definitely does help to impact tone. It improves body awareness. For speech and language pathologists, it facilitates tongue protrusion, provides opportunity for mobility of the lower extremities. So one of my favorite things to do, because so many of the patients have had strong hip extensor tone is as we're moving, my hands are on their femurs and I'm gaining more mobility until I can literally get my body between their legs. And so I'm walking with my body between their femurs to get that hip abduction, hip extension, external rotation, everything out of their typical adduction, flexion, internal rotation tendency. And then, like I just mentioned, may use as preparation for other positions, such as sitting. So the things we have to think about when we're putting our patients on their, in prone on the horse is, do they have G tubes, GJ tubes? Do they have an insulin pump, a baclofen pump? Anything that we need to protect there. And it could be something as simple as a little foam donut over that area. I have literally just put my hand there for the transition, but once they transitioned on, we were okay. Be aware of VP shunts, ventriculoperitoneal shunts, especially because with the head, if the head is down, then that can be creating an issue there. Again, additional training for your staff. Make sure everybody knows their job and how you're going to be handling the patient. And then how are you going to perform that emergency dismount in case you need it. Right. So then we also have like what we call prone on the rump, with the idea basically being now they're more prone, but their spines are aligned with the horse. And this is kind of the picture I chose here is kind of a little mix between a forward reach in a rear facing straddle sit and not quite all the way prone. But the wonderful thing about this position is just the variability of what we can do here. So we could have somebody that's more involved in this position where their head is turned and they're supported on the horse to an activity like this. So this was a little patient who was actually finger painting on the back of the horse. So our benefits are that we're getting a lot of weight shift across midline, so that we're giving our patients that awareness, that midline orientation, facilitating then the trunk riding reactions, giving them again that wonderful surface for upper extremity weight bearing, that strong proprioceptive input, facilitation to the diaphragm, and again, promoting jaw grading and mouth closure. So this is probably one of my most favorite pictures, even though this is like a what not to do, because the horse is not padded where her chin is sticking into him. And, if your patient has any allergies, I mean, you're just getting hair on them as well. So the padding should have gone further. But this was a little girl who used to come to us so hyperactive, and we would do lots of heavy work. She would push wheelbarrows, she would scoop feed, she would carry water buckets. And then this was like what she looked like at the very end of a session. And, she looked so angelic when she was done. She had not looked so angelic when she would come into us. But, this is more of a picture of what we're talking about with regards to the prone over the rump. It's just, again, we want to be protecting both patient and horse. So again, the considerations are that you're going to have the adequate padding. You're going to monitor the head and neck position to prevent micro trauma. So you can just imagine that if, obviously this picture was shot at a halt, but imagine if this horse was walking, what would be happening to her neck with each step that the horse took. So you need to be aware of that. Making sure that your horse has smooth, gradable movement. And then again, especially if your patient's going to be more head turned to the side, is what kind of helmet are they using? And is the helmet like getting in the way, and or is the chin strap getting to, pulled or torqued, or any way inhibiting the patient's breathing. And then there's supine, with the head on the rump. And this is a picture that I took from our manual. And so you can see in this picture that there's a lot of equipment on. So you can see that we have the soft helmet, because the big helmet would be too much for this child and be in the way in this position, and then also would be too heavy for bringing up to sitting. They use the boppy for additional support for this patient's head and trunk. And then you can also see the padding that they had here to bring the hips and knees into a bit of flexion, because if they just dropped these legs down, they'd end up with an excessive lumbar lordosis here. And so you can see in this particular position with this child in a nice midline alignment with a little bit of chin tuck, able to control those eyes and be interacting with the therapist. So it can be as simple as just providing a break from upright positioning. Your patient's fatigued and they want to lie back for a couple of minutes. Again, providing that midline orientation, like you saw so beautifully in that picture. Again, getting that lateral weight shift, side to side. Promoting opening and stretching of the anterior chest. So a stretch of those pectorals, a stretch of those shoulders that tend to be adducted and internally rotated can be opened. Getting a stretch to the abdominals and to the hip flexors. Getting a lot of sensory input, a lot of proprioceptive and vestibular input. Can facilitate swallow responses, because now that tongue is coming back because of gravity, and it helps to facilitate the k, g sounds. And then it can be used as a starting position to come up to sitting. And I know some people just like to practice a sit up. My preference is to have them rotate a little bit to the side and work on weight bearing through their arms and pushing up to come to sitting, but it depends on what it is you're working on. So carefully monitor the head position. We don't want a hyperextension. So if you want to ideally have something under the head, it doesn't need to be as big as that boppy. It might be one of those little mini boppies that goes around the neck. I used like a airline neck support, or you could just have a small pillow or a folded towel under the head, making sure that the helmet, again, is not inhibiting the position, or that the strap is creating undue pressure. We want to be aware if our patients are tube fed, that it's been a while since their last feeding. We want to avoid reflux and certainly aspiration. This can be a very anxiety-producing position. They're looking up, depends on where you are. They're either seeing the big roof structure of your facility, or in my case, we were outside, and just that huge expanse of sky is kind of unwieldy and many times a little bit, well, sometimes more than a little bit anxiety producing. So we've got to be careful with that. And just things like if you're outside, think about the sun and what kind of sun protection are you giving them. Again, make sure that those legs are supported in some way to prevent that excessive lumbar lordosis. Again, additional training of your staff is necessary. And again, consider what you would do if you had to transfer them off quickly. So I am going to stop sharing now. Now that we've all had this little review of alternative positions, again, other than we didn't talk specifically about tall kneel or quadruped. I didn't really have pictures. I didn't want to steal more pictures from AHA, but the idea of quadruped being a developmental position is they could be facing backwards where their arms would have a broader base of support and the knees would have a narrower base, or vice versa. So it depends on what you're working on. The thing you really want to be considerate about is the padding for the horse. And if your patient is wearing AFOs, you most likely want to take those off. But the thing that I see time and time again when people put their patients on the horse and quadruped is that they're not truly in quadruped. Their hips and their knees are quite flexed, and their knees are more under their abdomen than under their hips. So be thinking about, why you're doing that, and are you getting what you want? Because you could do this on an equicizer or a bolster or a ball or the mat or, so many other surfaces. And, it's just a matter of your patient and what you're trying to accomplish there. But it's very, very challenging for you, like how tall are you? Are you going to be able to support that patient? If you're, if you're at a walk while they're in this quadruped position. And then tall kneel is the other position that is considered a developmental position. And again, it's all those same precautions. You could be facing forward, you could be rear facing, take the AFOs off. And again, what is your patient looking like? If they're flexed and they're hunkered down, are you achieving what you want to be achieving? So that's kind of it in a nutshell. So now I think what we want to throw out there is, you guys talking about patients that you've had, things you've done, and, let's just start sharing information and then kind of coming up with ideas of how we might progress somebody. So if those of you who do not have your cameras on, if you are able to turn them on so we can all kind of chat amongst ourselves, that would be great. So Brianne, where are you?
Hello.
Give us some patient scenarios.
I actually have a new one that just started this past week. She is a higher level kiddo. She's about 6-ish, so small frame, small little girl. Not your typical therapy patient. She is lagging behind her peers. A lot of like jumping, the higher level activities, mainly because of hyper flexibility. She just barely missed the cutoff for, I can't remember the test the PT did. Michelle would have to maybe let you know what that is, but there's 9 zones to evaluate to see if they have some sort of hypermobility.
The Ehlers-Danlos assessment?
I think so, yeah. And she was like 4 out of 9. So not quite 100%, but she hyperextends her elbows like to like -20. I mean, it's pretty extensive. She uses her joints and those locking of those joints for support. So her strength appears better than it probably actually is. Just started with her this week, and she did fairly well, but she tired out really quick. And just trying to facilitate the proprioception we were trying to avoid that hyperextension. So, putting her in some weight-bearing positions helps with the strengthening, but she's also wanting to lock those elbows, lock knees, you know,
Right.
that type of thing.
Has she had any other, trying to think of like what specialty doctor she would be seeing, but just a doctor that would be checking her out for connective tissue issues and even like GI and heart and all those other things that oftentimes are involved with.
I don't think so.
Over
Mom
time.
has been a really good advocate. She has been pushing for intervention because
Mhm.
she's like, yeah, she's not keeping up with her friends. She can't do this. She can't do that.
Yeah.
One of the things she mentioned was she can't pull herself up out of the pool, you know, from the side. Just things that other kids her age can do. She's clumsy. She, you know, poor body awareness. So she's been pushing for therapy. That she saw therapy last year, and they said no, she's good, no follow up, she's fine, don't worry about it. And we're like, okay. So yeah, she's had OT and speech, I do believe, and they were the ones that expressed concern about the milestones and the flexibility issues. So she just literally, like I said, was evaluated, and definitely the hyperflexibility is there. She does have some ADHD symptoms, that type of thing. But as far as I'm aware, she doesn't have any specialists on her team yet. So her mom, you know, is very willing to look into whatever. So
All right, so I'm already formulating questions in my mind. What would you guys want to be asking her as far as gathering information on this little patient? Anybody? What does her gait pattern look like?
again, hyperextension at the knees. But
Wide base, heel toe. You might not have, I mean, if you just saw her, you might not have even
yeah.
looked at everything yet.
Well, and I wasn't there for the evaluation. I've seen her in clinic. We did an in-clinic day too, but we have a smaller clinic and we didn't do a lot of gait training or, you know, looking at running, jumping, that type of thing. We did more balance, and we did a lot of like balance beam. We did a lot of quadruped stuff to try to facilitate getting her to learn how to weight bear through those arms without hyperextension.
What
So
is
she,
her,
I mean, fairly
what does her
normal
sitting posture look like?
kyphotic on the horse. Kyphotic. I mean, not excessively.
Kyphotic at
Very
the
kind of like
thoracic spine, posterior pelvic tilt.
Yeah, kind of. She very much presents like a low tone kind of kiddo, just that very posterior tilt, kyphotic. But I mean, not as bad as I've seen a lot of kids. But yeah, she's kind of that floppy, weak core.
And is she a pudgy kind of doughboy kind of body, or is she thin, or what is
She's
she?
very thin.
Very thin.
Yeah, she's very kind of. I mean, she gives you the vibes of like a CP kid, just that very thin, slender, for her age.
I'd want to know what her ankles are doing, because if she's that hypermobile, you know, that can be something that's besides the hyperextension in her knee that's causing a lot of the clumsiness.
So yeah, so Bram maybe looking at her without her shoes and socks on.
Yeah.
To see what her feet are doing. Like, is she pronated, and if so, how severe is she?
And I don't have her evaluation in front of me, but I'd have to relook at that because I'm sure Michelle has taken a look at that.
Okay. Yeah, and like how's she using her toes even? Because that's very telling as well. And yeah, does she need some kind of anything from an shoe insert to an SMO, you know, thinking like a Sure Steps type of SMO which doesn't sound like she'd be appropriate for anything more than that, but those
Mhm.
would be the things I'd be thinking about. So when she sat on the horse, first of all, tell us about your horse selection process and your equipment selection process.
Well, we didn't have, unfortunately, much selection because she is in the time slot where there's two other children. There's an OT and another PT patient there. So we have, I think, again, Michelle could tell you, about 8 or 9 horses that we use for therapy. They cannot be used more than twice in a row, obviously. With 3 of us on Thursdays, each having a patient every hour or so, that gets a little tricky. So it was basically who was available.
Well, and that is
yeah.
the nature of many facilities and the struggle. So tell us about the horse that she ended up with.
I'm actually trying to think which one she has. She actually has a very, I think his name is yeah, I think it's Starbucks. I'd have to look. I'm trying to think, she had Fiona. I had 3 kids on Thursday, so I'm trying to think who had what. I think she had Starbucks, who is a little bit of a forward horse, has some decent movement to him. He's one of the more, say, more energetic horses. The handlers have to work a little harder to keep him not under control, because obviously he's not a horse like that, but he's just a little bit more energetic than some of the other ones. So he has a little bit more movement to him. He's about 14-ish hands, I would say, somewhere in there. So he's not super tall, not super short, and has a lot of trying to think of him. I think he has a lot of AP movement.
Okay. And what did you have equipment wise?
So she has, we have it's basically like a saddle pad, and it has stirrup attachments to it, and also some padding, so just a Western saddle pad underneath. So very light to start with.
Okay.
And then, so last week was just her first session. So we just wanted to see how she tolerated it. Was she nervous? I mean, she literally had not been on the horse yet. So, we just did the 4. We did do backward for maybe 3 or 4 minutes, but she got tired really quickly of that. But, yeah, we just had the basic to start with to see how she did. And then we changed that depending on how they tolerate it, how they're positioned, that type of thing. We have things like yoga pads and half pads. We have one horse that does have a little bit of a sway back. So we do have some wedge pads that we can put in there. We have, tons of different saddles. We are lucky that we have actual saddles, Western saddles, English saddles, saddle pads, dressage type saddles. So there's lots of choices. It just depends, again, who's using what too with the other 2 horses. So my 430 patient has kind of more of a saddle, which limits what we can do position wise, and actually stirrup wise. She doesn't have stirrups on her saddle. So, but the other 2 are using probably equipment I would use. So trying to find the balance of, well, she needs this, but somebody else is using it, or that type of thing. So
can I ask, what was she doing with her hands? Was she holding on to a center strap? Was she weight bearing on her hands? If you said you had her backwards, or no? You did have her backwards.
Yeah. So we a few things that we tried with her. We did do some kind of a jockey position, that weight bearing through the feet, putting her arms on the withers, just getting a feel for that. Try to do a little some sit to stands with control. We did do the backwards with just flat hands, weight bearing on the rump. That's what really fatigued her. She had a really hard time with that.
Did she lock out?
she wanted to. I had to do a lot of work to keep those elbows from locking out. Though she did follow the cues really nicely, though. She was really trying hard. I think it was also that extensor too, that weight bearing through the arms into the shoulders. I think she really tired out with that. So most of it was forward to stride. I also had her do hands on thighs. We also did things that occupied her upper extremities. Like we have this really awesome TheraPutty with little plastic animals in it. So having her up at like trunk height to work on that, not so much for the fine motor, that's helpful, but to help keep her arms occupied. So she was not, she was using more of her core and engaging more of her lower abdominal. So, and she did fairly well with that, actually. That was fairly easy for her. So it's the weight bearing, I do believe, would be great for her. So
Did you get a chance to see her scapulas when she was doing that weight bearing? Like, what was she wearing?
just a regular t-shirt. It was pink. So I mean, she's lucky that she's thin enough that you can see fairly well. And they were showing a little bit of some protraction.
Yeah, I'm curious to know how much winging she has in normal.
I'll have to pay closer to attention to how bad that is, but you definitely could see it, that it was trying to do that. Last week I was really working hard at trying to keep those elbows from being from staying locked.
Yeah, but I think you've kind of hit the nail on the head that if she's got a lot of weakness in her shoulders, she's going to lock those elbows as a result of the of the shoulders. If the family's amenable, you might even want to ask them to have her wear like a bathing suit top or a sports bra type of thing under her shirt that you could take off and take a look at her scapulas. Because upper extremity
we could
weight
definitely probably do that in clinic, but yeah.
What's that?
They'd probably be definitely okay with clinic. I'd have to see, how, because they also have like a schooling arena, and it's a public place where we do the therapy. So they have
maybe even a tank top, I think about what
a razorback,
it's where, that would still give you the same idea. But as anything that's going to make her fatigue is certainly going to be that's like ding ding ding, where the challenge is. So it does sound like you chose a great activity for her, being rear facing and upper extremity weight bearing. It just doing that with the dynamic surface is so much more challenging than the static surface. And I'd be willing to bet that she probably fatigues pretty readily on a static surface. So, with the family, they could be incorporating doing that on a Swiss ball, or doing that even on a squishy mat, even if they folded up a yoga mat several times, and doing, quadruped kind of activities on that would be helpful for her. Anybody else worked with a patient like this? Or Joanne, you have any other suggestions?
I mean, I work with a child that certainly has hypermobility, just your general low muscle tone. And I think a lot of times the actual weight bearing while on the horse is a little bit too challenging through the uppers. So incorporating a lot of, holding something, like a noodle over your head, or, you're getting the core work and the shoulder girdle at the same time. So occupy their hands like you've been talking about, give them a little stretchy noodle, or have them, hold rings. I'll put rings, lightweight rings like bracelets, and they're doing airplane arms. But just to get that stability dynamically is a good place to start, and work your way up to doing weight bearing. And sometimes I'll even have them forward facing, and so they would push out into my, like, I'll have my hand like this, and the sidewalker on the other side will have a hand like this, and I'll have the client try to push us at the same time. Usually they only push with one hand. They can't coordinate both, or it's just too much. But that way you're getting weight bearing, but you're kind of facilitating it versus having them dump, because a lot of times I feel like it's so hard for them to hold their body weight up right away. So they tend to lock out or kind of dump on their joints. So, start with arms up if they'll do that for you. They may just want to be on the strap.
She's very playful, very, wanting to do whatever. Yeah, we have like some weighted medicine balls with the handles. We have pool noodles, we have cones and all that rings that we can place, on cones reaching up, reaching over. So lots of that type of stuff. So
yeah, so that's great. I mean, that's very great shoulder girdle strengthening activities as well as your core. And so once you get that going, then go back to introducing a little bit of weight bearing, either backward facing or forward facing, and trying maybe like the sit to stand that you were trying to do. That's terrific. On the withers, placing the hands and seeing if she'll tolerate a little bit more.
I was even thinking of after the pushing out to the side, the next progression could just be prone over the rump with her forearms down to focus on shoulder stability first and take the elbows out of the equation for initially. So that might be a good little progression.
Yeah, actually, as Carol was talking about that, I was like, that one might be good. So I just have to check in to see to make sure the horse that we use is okay with that, because they all have their different little things that they're okay with and not okay with. So I think they're all okay with that stuff. But
the other thing I've tried is they like to brush. They like to brush the horse. So if you have like a tiny brush that they could hold, and have as you're forward facing or rear facing, have them, we're just going to brush a little bit. And so, you're getting the movement, you're getting maybe a little bit of weight bearing as they're brushing. That's kind of another thing that you might want to try. Of course, unmounted grooming activities would be great. But now we're getting off the horse.
That's an alternative position.
Yeah, the idea of the finger painting on the rump too, could be a good one. Joanne, I know you had other things to offer as well.
Well, no, I'm not sure what their situation is, but I know we usually start our kiddos in the clinic for the first part and then get on the horse. So a lot of the preparatory activities of doing some prone extensions over the ball, eliciting the protective reactions to get some co-contraction through the shoulders, playing in 4-point, or playing, like I'll put them prone over a bolster or a ball and have them do like a knee push-up where they're really pulling themselves, using their arms to get up onto their knees, onto the bolster, just for some prep beforehand. And I don't know, it sounds like her trunk might be adequate, because a lot of my kids that are that low tone can't lift their hands off the surface, so I don't want them on the surface because I want to work the core, because the development's proximal to distal. So, working more proximally, like they were saying too, working on the shoulders, girdle and the scapula before you work on the elbows.
Yeah, and we've got a swing too, and a therapy ball, and a platform swing. So we do some shoulder stuff with the platform swing too. So
yeah, helps them get a little prep work before you get on top of the horse.
I just wanted
one other. Oh, sorry.
Hold your thought for just a second. I just wanted to say hi to Susan, because I hadn't said anything to her before. And Susan, we're glad that you are here and have joined us. Susan is in Mexico and has a wonderful program down there, and she just does such amazing work, and it's good to see your face.
Yeah, it's been a while. We're busy. We have 54 kids now, so it's really booming. So it's hard to get on. So, thanks. 54. And we have a baby.
When are you
Mhm.
posting a course? Because that would be awesome.
Yeah, yeah. We have a baby horse now too. So she's only 4 months old, and she's already in the arena, getting used to seeing the kids, and we're introducing her just to like the rings and things like that. And she's very curious. And so yeah, we use her,
Mhm.
obviously. The kids are petting her and she's coming up to them and they're brushing her and everything. It's pretty cool. It's
That's
our
awesome.
first baby. So yeah, she's quite gentle right now. So that's pretty cool.
Yeah, that's amazing for a 4-month-old.
Yeah. We have no choice, like, so she's running around and she's bonding with the kids, and the kids are they really respond obviously to the baby, and the baby is just really responding to the kids. So it's really cool to see that she's actually in the arena sometimes, just, with the kids, and they're petting her like a little petting zoo. And yeah, it's pretty fun. Well,
That's
thanks.
great.
Good to be back.
Yeah. Go ahead, Laura.
Oh, so I was just thinking the sideways position might be a good place to, although it's a much narrower base of support, but if you want to facilitate a protective reaction maybe, and see if she'll start putting her hand down a little bit to catch herself repeatedly, that might be also a way to start getting a little bit more weight bearing just through that protective response.
Thank you. Yeah, I'm over here trying to figure out what kind of doctor your patient should be being referred to, because I'm just really struggling with the fact that she doesn't have a diagnosis, because I feel like there's something underlying going on that probably should be identified.
Usually orthopedists, I think, do Ehlers-Danlos, right?
Maybe it's developmental pediatrician.
Or a physiatrist.
Physiatrist might be too, yeah. Because
Yeah.
she was like 1 feet away from that positive, and her thumb was like this close to touching her wrist. I mean, like it was just barely a negative. So she definitely has some sort of, connective tissue or hypermobility issue.
Yes, exactly. And
Gotta be
yeah, I
something.
mean, and yes, on the ortho, but
Geneticist, maybe.
geneticist, yes.
Mhm.
I don't know. That's such a big jump. I don't know if the parents would be willing to go that far. That's why I'm trying to think of something like,
A rheumatologist.
the developmental
I mean,
pediatrician.
I think developmental peds probably, because they're used to kind of seeing,
Yeah.
okay, there's some delays here, there's some sort of abnormality here, and then
Right,
they're the ones that typically refer to, okay, well
Right.
then we want you to see
right,
YZ or some sort of specialist or a rheumatologist or they're the
exactly.
ones that typically will.
Exactly. Yeah.
How are her hips? Are her hips really hypermobile as well?
I did not assess them. I'm a PTA, so yeah, I mean she's she's fairly flexible. She has no problems riding astride at all. I mean, no issues retro either. I mean, she's definitely got great abduction. But again, surprisingly struggles with she's not like super bad with the single leg stance, but you could definitely see the perturbations, the glutes, having to really work. Just all the
Well, she
joints seem
feels
to be kind of unstable and
unstable. Yeah. So I don't
Mhm.
know. I mean, if she were mine, I would probably suggest to the parent or to talk to their pediatrician about an ortho consult
Mhm.
just as a starter, because
for the joints the way
just
they are. Yeah.
for the joints, it's a joint thing, hypermobility, and if she's feeling if you're seeing instability, then that would be my first choice to say, okay, let's just get it checked out. And it's easier for a parent to kind of like, ortho is just easier to absorb than genetics. Genetics, you're like, oh my God. But ortho, and a good pediatric orthopedist should be able to identify a hypermobility.
If it's progressive too, like you should ask the history, whether or not she was always like that, or is she more like that now, or did you notice things when she was younger? Or was she just getting this now? Or, you know, because there's these, I've had some really rare things in Mexico where they've actually been stronger when they were toddlers, and then the weakness and hypermobility things start showing up when they're older. It's weird forms of dystrophy.
Like an
you know.
SMA or something.
Yeah, yeah,
Mm.
some kind of weird dystrophy that they're getting worse, not better.
Yeah, yeah, that's why I was kind of pushing more for the more of a
Mhm.
generalized physician as opposed to just ortho, because I think you'd go to ortho, but then you'd end up somewhere else anyway.
Mm.
Because I feel like this is more potentially more than just a joint laxity
Mhm.
issue with this
Yep.
girl. So
Yeah, and I would say she's a typical 6, 7 year old in every other respect of her
Yeah.
behavior, her cognition. I mean, she's very much a typical rambunctious, funny kid. So just very thin, a lot of excessive mobility, and obviously some weakness in those joints.
Is there a family history of hypermobility?
No.
Okay.
I do have a kid that I was seeing and using hippotherapy with, who has the Ehlers-Danlos syndrome. And so I know you said this one has more kyphosis, but it might be good to just keep an eye on her low back, because this little guy, well, he's like, I guess he's 12 now. I think I saw him on the horse when he was 8 or 9, but his biggest problem is low back pain. And I think he's just got excessive lordosis.
Well,
And, but he was really smart too.
Yeah.
And he was able to work on the mat to learn about posterior pelvic tilt and just the whole pelvic mobility,
holding it, yeah.
and trying to stabilize. So, maybe she looks kyphotic now, and maybe that'll stay for her. Maybe it's different, but I
I was
just
going to
feel
say
like
when she's sitting, she's kyphotic, and it's not excessive. I mean, it's just a slight. It's just, I call it like the teenage boy syndrome, where they just kind of sit there, they just kind of hang. So it's not really a true kyphosis. It's just she's just kind of, hanging there. When she's standing, she does not have kyphosis. And I would actually probably say, yeah, she probably is leaning more towards a slight lordosis in the low back when she's standing.
And these are going to be kids too who might be aggravated by wearing backpacks and lugging their books.
And she's tall, right? You said she's tall.
I have a really hard time judging her age. But she's not a short kid. Yeah, she's either average or tall for her age. Yeah.
Yeah, because that's even tougher, being tall and hypermobile and low tone combined.
Well, you'll have to keep us posted on this one, Brianne.
Yeah, I will. I'll see if I know that they usually sign releases when they sign up for hippotherapy, but I'll have to double check with their mom and see if I can maybe get together more a formal case study for her.
That would be perfect.
So I can give you more of the history and that type of thing too.
That would be great. Yeah.
But yeah, she's going to be fun though. She's such a sweet little girl and she is hilarious. So
nothing like having one that entertains you while you're working with them. All right. So how about, does anybody have anything to share? Everybody had raised their hand when I asked, have you used alternative positions? So can you give me an example of a patient that used alternative positions, or you feel like at certain diagnoses you tend to use them more, or any actual treatment scenarios that you can share?
I have a little girl with a diaphragmatic hernia who is really, really interesting. Normal intelligence. Had a lot. I mean, when I first started with her, because of the scar tissue in the abdomen from all the because they put mesh in there to replace the diaphragm. So there's a lot of scar tissue. She even had a bowel blockage when she was younger. So they went in and released a lot of that scar tissue that they found. But the one thing that was interesting and that worked well with her was riding prone on the horse over the barrel. Because the movement of the horse, I think, helped to mobilize that scar tissue in her, in her abdomen and stuff. And, I mean, I saw her for maybe 2 years. I don't see her anymore, but she was very symmetrical. Her gross motor skills came up to be age appropriate. Like I said, her trunk asymmetry, because on the side where it was, she was more, I think, because of the scarring, I think she was more rotated back on that side. So she had that tendency to become more asymmetrical. And I know that's a problem with diaphragmatic hernias and their, but she was symmetrical by the time we finished with her and had pretty good breast support. I did use some of the breathing stuff with her too. But yeah, so I thought that was a fun thing with her being prone to help mobilize her scar tissue.
Very cool. Very cool. Yeah, I love it. Yeah, that is a very tough diagnosis and they have a lot of complications. So the fact that you attained all that for her is wonderful.
Yeah, and she was playing soccer, she was doing gymnastics, she was, age appropriate, but not when we started. She was very toed in. That all switched. She would trip a lot. She had knocked out teeth, but by the time we finished, her gross motor skills were age appropriate, and so was all of her tone and her symmetry. So she looked really good. It was
That's
fun.
awesome.
It was a fun one to work with.
That's great. Anybody else have any?
I think a lot of my autistic kids, they prefer backwards. They just enjoy it a lot more. And some of them just close their eyes and just to get more of it. And I use a lot of sideways on them just to get that joint attention because it is alerting and it does get their attention and I can get the eye contact better because we do a lot of, we try to do a lot of the speech therapy kind of things where we're trying to engage them and get joint attention and use the buttons and do more things and imitation of sounds and things like that. So I use sideways a lot for them. Except for one of my autistic kids, for the very first time, she never did it before. For the last 2 times, she just randomly would stand up, like literally stand up on the horse. And it was really scary. She's pretty dang stable on it, which is amazing. But I'm like, oh man. So we had to figure out a way to safely get her from standing up to sitting back down again. I've never had that before where she just boom, and I'm pretty short, even though we have a short horse, she's still kind of up there. And thank goodness I had a taller side guy, but she was really, really stable. But I'm like, okay, how do I talk her down from that? That was a challenge for us.
So when she stood up, where were your hands? How were you stabilizing her?
When she stood up, I was like freaked out at first. I'm like, oh my gosh, what is she doing? And so both of us, I had my hand on her ankle to keep her down there. And then I grabbed to stabilize her knee so she wouldn't buckle. So she's stable there. And she was up there, no problem. I mean, she's very autistic and she was queen of the world. She's like, I'm on top of the world. Like she had no fear. I was like, oh man, so I'm like, okay, she's there. I grabbed her knee so she couldn't buckle, but how do we get her down there safely? I'm like, and then finally we just said, okay, like Emma, sit down. And then finally she did, but it was like, that was new for me. That was like, what are we going to do? Happened a couple of times then. So the first time was scary. The second time, at least we knew she was going that way, but that was challenging because she's not short and she wasn't a toddler, like she's 7. So she was up there. But yeah, we use a lot of, I like the backwards too, because then we do a lot of activities with them back there. At the bump, because they can do the finger painting and we do whiteboards and we do crossing this and we do a lot of writing and different things to get them writing and paying attention and things. So those are the positions I do. My biggest struggle is having kids that are hypotonic, super hypotonic, and they're just floppy. And those are the harder ones to find positions that help them. those are the ones that I have a hard time figuring out how to get them into that anterior tilt when they're just really floppy.
And how old are they and how,
Well, the
Big
one
are
that we
they?
have is super floppy and he's actually 4. But he doesn't look like a 4-year-old, he's probably the size of a 2-year-old, but he's 4. And
Okay.
we don't know, you'll never find out his diagnosis, who knows what it is. And he does get better. So I just have been using just the pillows and that one that I bought at the class
the hippo helper?
that's the one. Yeah,
Yes.
we do that one. We use that. But it's still, that's great to get his elbows on there and get his head going, It's just, sometimes you don't have enough hands, like,
Right.
for kids like that. And it's just, he's still, no matter what I do, he's just, he's going into a posterior tilt. And now he's getting a little stiff in his upper body, like a thoracic kyphosis. So then we do put him backwards over the horse sometimes just to stretch him out a little bit.
Okay.
But
Okay.
I do
Are you
like
putting him backwards over the barrel?
both over the barrel, but not so far over that he's completely upside down.
Yeah.
And then the other way I saw that you showed me that I just remembered, I said, oh, I should do that with Manny, is to put him the other way with his head on the rump and then have him in that boppy maybe, and then bend his knees up. I don't know, just to get him some kind of different positions because he gets pretty tired. He fatigues easy.
Yeah. Yeah. With him being that tiny, I would think prone over the barrel could be a great position for him with something under his chest. And then just, horse well padded, but weight bearing through the elbows and lifting the chest and lifting the head. And that's probably going to give him as much support as you can possibly give him and be as easy for you to control him as possible.
Yeah, that's true.
But still be giving him so much sensory input.
Yeah, it's just, his head control is better, but he's pretty floppy. So, he has trouble swallowing and things like that. He's just really, really weak. But the horse is definitely helping him. It's making a difference. We just have to be super, super careful of so many things when he's on there. So his head doesn't move too much and, so he's not back, hyperextending at his neck and he's just jello, basically.
And what kind of helmet are you using for him?
Soft one, because he can't lift it. If I put anything on him, he's just down.
Yeah.
So we have a soft one that we use for him. Yeah, he can't, if I put anything else on him, he can't move.
Right.
He's down.
Exactly. Exactly.
I was gonna say, I know Michelle uses an abdominal binder sometimes with some of those really, really floppy kiddos.
We
Just
thought
because-
about that. Yeah, we thought about that. I just don't know. Like we're in Mexico, so we use Ace bandage. I don't know if there's any commercial types that I can buy or something, or is it just we have Ace bandages? Like we don't have, we're not in the US, so we don't have abdominal binders necessarily.
Yeah, well, I mean, I think it's the post-op, like, if you know what I'm talking about, it's just an elastic.
Elasticy.
Stop.
It's got a little stretch to it, right?
Yeah, it's not like a medical device. Like you get one probably on Amazon or something, but I'm not sure what resources you have. But yeah, it's not a high-tech thing. It's not a
The stretchy band that with Velcro or something, right?
yeah, basically. And they use it a lot, like even with after G-tube surgeries or abdominal surgeries or anything, just to kind of help keep that together.
Yeah, we use that
so
for him. We do use
a
that
lot
at
of
times. Yeah, we use that at times for him. That poor little kid. He's got GI issues out the yin yang. He's, constipated, then he's diarrhea, and then he's just so frail.
Yeah, that's a great idea. I think the abdominal binder could help him. Yeah, I mean, I'm looking at these pediatric deluxe abdominal binders, I mean, they're as inexpensive as $10.
And where are you looking on that?
I just Googled pediatric abdominal binder.
Okay, then.
Yeah. So there's a 3-panel binder. Yeah, there's for infants. I'm trying to find, one that,
Kind of the size of a toddler, I'd say.
right.
Well, if they're inexpensive, I can order them and then send it to my San Diego mailbox, and then I go up once a month, I can pick it up.
But, you know, there's also somebody showing in here in this picture, just kind of a figure of 8 with an ace wrap too. So I think that you could, Susan, you know, get just the widest ace wrap that you can get. The key is that you want to be connecting the lower ribs with the pelvis. So basically it's doing the job of the rectus and the obliques and holding everything together. And then that's just helping to provide a little external support in order to have a little bit more internal intra-abdominal pressure.
Okay.
So, you know, you could get by with that. You know, I think that should you find something that you think would work, let me know. I'll buy it for you and send it to your address.
Thank you. I will look it up.
Okay, anybody else who here has experience putting somebody in tall kneel? Heidi,
Very
you
low.
want to share who you did that with?
So I had some higher level kiddos for a while. I grew up vaulting, so I feel like it's always in the back of my mind to do a little
Awesome. Okay.
those stupid things. But we had a kiddo who was almost at the end of kind of his time with us and had a lot of core strength and everything like that. So we would do some more like we did start to incorporate like some vaulting postures with the surcingle and things like that. So it wasn't like a highly involved kiddo that needed a lot of support in there, and he was able to come upright because we've tried to do like tall kneel and quad with a lot of kids who do just kind of sit back, and so it's not really doing anything different. But I think I've had like one kid that was able to do it kind of how we would like to see it, I guess. And it still took like some tactile cueing and things like that.
Well, it's so cool that you have the background that you do in vaulting, because I just think vaulting is amazing. And you know, I remember watching some developmental vaulting demos and just thinking, oh my gosh, that's just so cool. So did you vault competitively?
I did, not like super, I mean, I wasn't like great. I just I had fun doing it, but we went like to nationals and did team stuff, and I feel like I would love to kind of do that therapeutically at some point too, just the team aspect of it, and
Yes.
everybody's working together to take care of the horse and
Yes.
all of those pieces
Right.
were huge.
Yes.
So yeah.
Very cool. All right. Anybody else have anything you want to share, ask? Now's your time.
I really like laying supine on the horse with kiddos that have a lot of not just kyphosis but the pec tightness. So a lot of our CP kids tend to, you know, high tone kiddos. So not only does it help stretch out, you know, that trunk, your pecs here, the rib flaring, you know, working on the rib flaring, and also depending on how hypertonic they are, you know, get a little bit of a hip flexor stretch in there. So with movement of the horse, that kind of tends to relax them a little bit and allows a little bit more of some flexibility and some stretching with less discomfort. Because a lot of these kids are used to being stretched and they really don't like it. So
yeah, for me, I think the biggest challenge is, you know, where's their head in relationship to the horse, because, you know, their head's going to kind of be at the lumbosacral junction area of the horse, and then where's their legs, and how are you supporting them, and how are you supporting their head, and then how are you making them feel confident like they're not going to fall off, because here they are, they're moving like this while they're walking. So I tended to find that I liked having like I would have a forearm like either over their chest or over their pelvis, and then my sidewalker would do the same on whatever, the chest or the pelvis, whichever one I wasn't on. And that still freed us up one hand to be somewhere else depending upon the patient. And that way I felt like they were getting a little bit of approximation through their body so that they didn't feel like they were going to slide one way or the other. But I always felt like that was one of the biggest concerns, was they were so apprehensive about the movement, added to this position. But I'm in total agreement. It's such a lovely position to get that anterior chest stretch, the rectus stretch, the hip flexor stretch. And I would tend to do them like I stretch hip flexors off the horse unilaterally, so I'd have something under one knee and let the one leg hang down. And then I would do it with the other. So I wasn't just getting the lumbar lordosis that you tend to get.
Yeah, so we use the stirrups. So we have the breakaway stirrups. So that way the opposite leg is supported, and that way you take one leg out and stretch a little bit. So that they can feel a little bit of some support through their feet.
So their feet are all the way in the stirrups, but they're lying back?
The way our saddle, it's a saddle pad, so it's
Right.
flat on the top,
Right.
and so the stirrup leathers they're not straight down, you know what I mean, they're kind of this way, so their legs are still, I need to get a picture, but yeah. It's not their whole foot, it's like the toes, the forefoot is kind of supported there.
Okay.
And then we've also done it where just the opposite volunteer can help support that leg on the opposite side while we're
Okay.
stretching the other one.
Okay.
And then I've also used a towel roll, small,
Yeah.
soft towel roll underneath their back, because that lessens, that helmet is so thick in the back that limits this kind of thing.
Right.
The
Right.
forward, the chin thrust there.
Yeah. 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 That's why having alternative helmets sometimes when they're in this position can be helpful, because those helmets do definitely get in the way. Or, what I found was having one of those airplane head supports raised everything up a little bit so that the helmet wasn't against the horse so much. Everything was kind of lifted up a little bit up off the horse so that you weren't dealing with that pushing of the helmet into the back of the horse and then shifting on their heads and creating all those other challenges. But yeah, I guess I tended to do supine more in the pool than I did on the horse. I just always felt a little more apprehensive with them on the horse, but I agree with you. The benefits are really good.
Well, I mean, I even do it, I won't even say that we do it a lot, dynamically. We do it, we'll take breaks. Okay, let's lay back, stretch. We'll do maybe a couple strides or half of a circle or something, but nothing extensive. Like it tends to be more of a kind of a resting position. I guess I would use it more
Yeah.
of.
Yeah. Short periods of time. Yeah. Yeah. Mary Helene had one of the AHA faculty had gotten a big foam wedge, like you might use just to prop somebody up in bed. And it was like egg crate. And that was really nice because the way it was designed, it had a little bit of a concavity to it that fit either the horse or the patient, and putting that on and then lying the child on that was great because they got the movement, but they were more supported by this foam. So they were receiving the movement, but they weren't, the contour was different. So they were more supported. All right. Any other questions? Any other comments? Any other thoughts of what else you'd like to talk about in a future meeting? You guys aren't helping me much.
I have kind of a interesting thing just to throw out real quick. I have a 10-year-old little guy who is very impacted. He has polymicrogyra and he had a stroke in January. Mom wanted to try him on the horse, so we're doing that, but he falls asleep every time. And I wondered if anybody else had ever had that experience. And he's very floppy. So I have a neck. Sometimes I put in one of the Hunsinger collars on him, but he did better this last week. But have you ever had a kid fall asleep on the
I
horse?
did in the pool. I haven't on a horse, but obviously I would think that the rhythmic movement is just very relaxing for this child. What position do you have this child in, and how long into the movement does he fall asleep?
Well, the first time we just had him on a bareback pad because I wasn't sure if this was even going to work. He was so posteriorly tilted, and I put a wedge under him, and that didn't help. He fell asleep before we even went half a lap, and he
Okay.
stayed asleep. And I thought, okay, I was looking for the proprioceptive input in his spine. He has all kinds of adaptive equipment. Sleeping is a big part of him, and it kind of comes and goes. And then last week I had him in a Western saddle with stirrups, and I didn't use any other supports on him, and he stayed awake for probably 12 minutes.
Oh,
And
okay.
he was upright, but boy, was it a lot of work.
For
And
you or for him or for both?
both, and both of this, we were holding on, and then we were pushing, trying to get his trunk up. And if we used we call it the ugly couch. It's that what Susan was talking about, the horse helper thing.
Oh, the hippo hopper?
Yeah, we got one. I ordered one, and it came with the ugliest fabric ever, so we call it the ugly couch. And any support like that, he falls asleep instantly.
Yeah.
You can't keep him here. And so I'm really struggling to try to decide, maybe and he has a G tube. Maybe we should try supine though, and see if that does anything for him.
Sounds like he'll be falling asleep in that position. I think that would be the most likely one for me to fall asleep in.
Mhm.
So the question is when he's sitting astride the horse. So first of all, how old is he?
He is almost 10.
Okay. So how do his hips look when he's on the horse?
Oh, great. They're great. His favorite thing to do is frog, and always has been. And there's no issues. Everything is symmetrical.
Okay.
But
you said he's in a very posteriorly.
Yeah.
So how open can you get his hip angles? Can you get him really open where his femurs are coming like down?
Mhm.
And so that you can get his pelvis in a more of an anterior tilt?
Mhm. The saddles seem to help a lot.
And I get him in a better position
it's
with
like
a cantle that's going to bring him forward.
Yeah. And that seemed to help an awful lot. But I was kind of struggling with the horse we have him on is very smooth. And I was thinking,
sounds like he needs a concussive. He needs a concussive horse.
Yeah. And then I thought, well, even if he's on for 10 minutes, at least he's getting more force than I can do on a ball.
Oh, absolutely. Do you have the luxury of multiple horses?
Oh, yeah. Mm-hmm.
Okay. Yeah, because it does sound like if you got a horse that had with a little straighter shoulder and a little straighter pastern, that could give a little bit more concussive nature or a little more vertical movement, could be a little bit more arousing for him than.
I was kind of thinking, if we put him on something that's more smooth at first, then maybe he would have more time to recover, with the motion of the horse. But I think you're probably right. I think we'll switch him to a horse that's maybe got a little bit different gait pattern.
Yeah, we've got to keep that reticular activating system working and keep him awake. And
Mhm.
so you think about, I hear what you're saying about that, give him time to accommodate to the movement, but if his accommodation to the movement is sleeping, then we need to,
His caregiver, he has nursing care around the clock, and the caregiver that brings him says he's worried. That's why he's falling asleep, because he's checking out because he's worried. And then when you ask him using his eye gaze, he says he likes it. But it's like, okay, I've never had a situation like that
sounds like the
before where-
caregiver is putting their anxiety on him. So
It
I
could
would
be.
not tend to listen to the caregiver. I would definitely listen to the patient if he's
Yeah.
saying he enjoys it. But if sleeping tends to be his issue, and that nice rhythmical movement that we all really, we know is so desirable for therapy for many of our patients, but not all, it sounds like you just need to find a different way to keep him more aroused.
What does he do with his mouth? What if you gave him something to like occupy, like to
he
chew
can't-
it? Does
He
can't?
chews his fingers, but he doesn't have
Okay.
hardly any functional use of his hands. He's
Okay.
just
What about
really,
What about music?
we've tried that. We've
Okay.
tried rap music, we've tried country.
Yeah, I was
we've
gonna say
tried-
something to like, you need to get him like wake him up a
Well,
little bit,
and
alert him.
prior to, I stick him on our we call it Wiggles, but it's just a electric saddle that does different movements, and he's awake for that.
Mhm.
And I can turn it up or turn it down, make it go more lateral, make it dip forward.
So he
And
needs that. He needs that.
yeah, it's just he's 54 pounds. He's like, gosh, he's just hard when he falls asleep. It's like,
Yeah.
I don't think we're doing any damage to him. But it's like, it's a lot to hold him up.
So when he falls asleep, what do you do at that point?
We stop and we put ice cubes in his hand. And we put cold wash rag on him. I jiggle him. We do legs. I kind of, and then when we get off the horse, he wakes right up.
So could it be behavioral? Is he really asleep, or is he just checking out? Like she said, it's possible. Like maybe this is something like manipulative. Like
He snored. He's snoring
snores.
when he falls asleep.
Okay, all right.
And he can fall asleep he fell asleep in his walker the other day when I was doing gait training with him at his house. So it's like, I think he's had so much medical intervention that I think there's something that is not regulated. He'll go like 2 or 3 days without sleeping.
I was going to say, does he have like a sleep apnea or something? Because that sounds awful lot like he's
on a
unable
CPAP.
to.
He's on a CPAP, and he doesn't have tonsils or adenoids. He's just really medically complex. And, we used to work with him on the horse a long time ago, and he was way easier to manage. And then now he's like, he can roll supine to prone and prone to supine. He lost the ability to sit up when he had his stroke in December. And so he can't sit upright on the floor at all, but he can sit upright in a chair, like in bench sitting. He can do that. So I'll try a different horse and see.
Yeah, and then, like you said, the supine, you might at least use the supine as the position to place him in when he falls asleep, as opposed to you trying to physically hold him up.
Well, and I might put him prone too. I put him prone over a really, really huge therapy peanut, and you know, to work on trunk extension. He's got a little bit of a kyphosis as well in his thoracic spine. So I don't know. I was just like, is it okay that he falls asleep? To me, it seemed like that's probably not very productive. But he's
Well,
still,
no, it's not, once he's asleep, whatever you're doing is not beneficial, but the time that he's awake and the fact that you got 12 minutes, 12
Mhm.
minutes is a pretty good amount of time for use of this tool. And
Mhm.
so if you get 12 minutes, that's actually great. And
You
then
know-
if you take him off and he wakes up and you can do something functional after that.
oh, I did. I put him back on our electric saddle and said, "You're not done yet, buddy," thinking that it might be avoidance or behavioral, because I didn't want him to think, you know, oh, as soon as you fall asleep, I'm going to take you off and you get to go in your chair and go home. So I didn't do that. And he did stay awake on the electric thing. So, well, thanks for your suggestions. He just is, you know, I'm kind of scratching my head, and Mom is like, she's doing everything she can possibly think of. He does water. He does, I work with him at home. I work with him at the barn. He has OT, he has speech. And, you know, I said, we give it a good try and see what happens.
I know vagal stimulation is a big thing now with stroke patients.
Mhm.
Might be something to look into.
And does it maybe make sense to put something overlaying, like using a bubble machine or something like that, to, you know, on top of those things that you said, like a saddle maybe for a longer period of time, and then is there something that would keep him engaged that you could offer him during the time too, like
Offer who?
You know, the only other thing I can think of are those little toys that you push the button and they have lights. He does not have a seizure disorder anymore. I don't know what they did, but he's been seizure free for 5 years. So that might be something just to catch his visual attention.
yeah. Yeah, or even like some of those, I like using these soap bubble guns that have like, some have a light and then some make music even.
Mhm.
And especially for some, you know, more involved children, especially when I work on trunk rotations and stuff like that, I like to use those because they really want to look at them. So I thought maybe this could be engaging for your patient.
I have one, so I'll write that down too and bring one.
Maybe, yeah, I don't know.
For who? To
I
my
Well, thanks, everybody.
Sure. All right. Well, you guys, my email is hippopt@aol.com. So if you think of an idea that you want to discuss, please let me know, because it's getting old for me to have to keep coming up with all of this. So I do need input, and I do appreciate Brianne's suggestion and some of these complex patients that we've discussed today. If any of you want to present them as a case study, you know, and can collect a little video and get us some more in-depth medical background, and the family, you know, is willing to let us discuss them, that's always, you know, that was really what this was all designed for initially, to kind of problem solve a patient or a patient's diagnosis. So let me know.
Yeah, I'll see if I can do that for my little girl.
Okay, that'd be great. All right. Thanks, everybody. Esther, when do you go back to Germany?
September 3rd.
Okay. All right.
Yeah.
Well, safe travels back. We'll miss seeing you for a while.
Yeah, thanks for having us. Hey, can Maya show you something real quick, Carol? So show her real quick.
May you always have I can't.
Get a little closer, Esther. I can't see.
Say it again, Maya. What does it say?
May you always have cows around
May you always have cows around, it
and
says.
a cow.
Thank you, Miles.
Thank you for that. He's been waiting. He's like, he really likes you, Carol.
Oh, I love him. Pumpkin.
Bye,
Oh my gosh, you
Carol.
guys are gonna be so much bigger the next time I see you.
Yeah, probably. Hey. Yeah.
Yeah.
Cool. No, thank you. This has been really, it's always super interesting to hear what everybody's doing and getting so many ideas and so many thoughts again. Yeah, thank you so much. And the time you put into this, Carol, this is like a whole clinic. Really, it's so amazing. I like to watch the recordings when we're meeting, but I sure like this live one a lot better.
Well, we love the fact that you join us when you can.
Thank you. Okay,
All right.
thank you. Yeah,
Bye. Bye, Miles.
Bye, thank
Be
you.
good.
Bye.